Hi everyone, I welcome you all for this Nursing Wisdom channel. Today we are going to see about postpartum hemorrhage. The word postpartum hemorrhage meaning post means after, partum means giving birth, hemorrhage means bleeding. So from this word we can understand that postpartum hemorrhage means the bleeding occurs after the birth of baby. Next definition, quantitative definition. This is according to amount of blood loss. The amount of blood loss more than 500 ml in singleton vaginal delivery. The amount of blood loss more than 1000 ml in twin vaginal delivery and cesarean delivery is considered as pph. This definition is as per WHO. This definition has some limitation because women with anemia even with loss of less than 500 ml lead to shock, and accurate estimation of blood loss is very difficult, usually underestimated. So we have clinical definition. It is according to the clinical symptoms of patient. Any amount of bleeding from or into the genital tract following birth of the baby up to the end of the puerperium which adversely affect the general condition of the patient evidenced by rise in pulse rate and falling blood pressure is called postpartum hemorrhage. According to American College of Obstetric and Gynecology suggested a clinically more relevant definition of pph that includes hematocrit drop by 10% or hemorrhage that requires immediate transfusion is called pph. Next, incidence. Incidence of pph is increasing in all settings globally. The incidence is about 1% amongst hospital deliveries, 4 to 6% of all the deliveries. In US, pph rate increased 5-fold. Across Africa, there has been a 10-fold increase. Next type of pph. First, according to the amount of blood loss. If the blood loss is less than 1 liter means it is considered as minor pph. If the blood loss is more than 1 liter means it is considered as major pph. And if the blood loss is more than 2 liter means it is considered as severe pph. According to the time duration, we can classify the pph into primary pph and secondary pph. Primary pph means hemorrhage occurs within 24 hours after the birth of the baby. Further, we can divide the primary pph into two types, third stage hemorrhage and true pph. Third stage hemorrhage means bleeding occurs before expulsion of placenta. True pph means bleeding occurs after expulsion of placenta. Next, secondary pph means hemorrhage occurs beyond or after 24 hours and within puerperium. It is otherwise called as delayed or late puerperal hemorrhage. Next, causes of pph. The causes includes 4T, that is tone, trauma, tissue and thrombin. So to remember easily, we can remember as 4T. Tone means normal contractile condition of uterine muscle. So any factor that interfere with uterine contraction leads to pph. The risk factor causing atonic uterus includes grand multipara, overdistension of the uterus due to multiple gestation, fetal macrosomia and polyhydramnios, malnutrition and anemia. Antepartum hemorrhage includes placenta previa and abruptio placenta, prolonged labor, anesthesia, induction or augmentation of delivery by oxytocin. Malformation of the uterus includes septate uterus and bicornate uterus, constriction ring, precipitate labor and tocolytic drugs. Next cause is trauma. That means any injury that occur in birth canal during birth process leads in pph. The trauma includes injury occur in forceps vacuum delivery, episiotomy wound, laceration or tear in genital area, paraurethral tear, cervical tear, rarely rupture of uterus, uterine inversion, vulvovaginal hematoma, broad ligament hematoma. Next cause is tissue. Retained tissues, bits of placenta, blood clots interfere with uterine contraction and leads in pph. Next cause is thrombin. Coagulation disorders can play a significant role in both primary and secondary pph. Pregnancy-related coagulation abnormalities includes idiopathic thrombocytopenia, preeclampsia, disseminated intravascular coagulation. Causes of DIC includes preeclampsia, fetal demise in the uterus, infection, placental abruption, amniotic fluid embolism. Congenital coagulation abnormalities includes hemophilia, factor XI deficiency, von Willebrand disease. Next causes of secondary PPH includes endometritis. Retained product of conception includes small pieces of the placenta or fetal membranes, subinvolution of the placental site, retained blood clots, uterine scar dehiscence following cesarean section, coagulopathies. Thromboplastic disease includes rare tumors, growth arising from pregnancy. Pre-existing uterine disease includes uterine fibroids or cervical polyps, and the risk factors includes history of primary PPH, mode of delivery, manual removal of placenta, prolonged labor or infection. Diagnosis and clinical effects. First one is vaginal bleeding. In the majority, the vaginal bleeding is visible as a slow trickle. Next alteration in vital signs includes tachycardia and hypotension. State of uterus. In atonic hemorrhage means the uterus will be flabby and becomes hard on massaging. In traumatic hemorrhage, the uterus will be well contracted but bleeding will be there. Next, management of postpartum hemorrhage. This is the algorithm of PPH management. First one is call for help. Request to bring emergency trolley PPH kit. Inform senior midwife, obstetrician and anesthetist. Next, we need to do initial action to the patient. That includes make the patient lie flat, start high flow oxygen administration, then massage uterus. Consider bimanual uterine compression. How we will do bimanual uterine compression means need to put sterile glove, then insert right hand into the vagina, form a fist in the anterior fornix and apply pressure against the anterior uterine wall. Place the left hand on the abdomen, cupping the fundus and compressing uterus between these two hands. It helps to apply firm pressure over uterus and help to stop bleeding. Next, insert 2 large bore cannula, mainly 18 gauge, and collect blood for investigation including cross matching. Then start IV fluid replacement, oral and NS alternatively, up to 2.5 to 3 liter according to the condition of the patient and amount of bleeding. Then need to assess for blood loss. How means by using visual assessment chart. Here visually we will see the blood loss and approximately estimate the blood loss, or if you want to get accurate amount of blood loss means we can weigh the underpad soaked with blood and can get the amount of blood loss. Next, assess the cause for this bleeding, that means 4T: atonic, trauma, tissue or thrombin. Among these, what may be the cause we need to assess. Next, to stop bleeding, we will administer injection oxytocin 10 units IM or slow IV, or injection ergometrin 500 mics IM. Avoid ergometrin in patient with hypertension. Next, we will administer injection tranexamic acid 1 gram. 1 gram injection tranexamic acid dilute in 100 ml NS, give over 10 to 15 minutes. Injection tranexamic acid is antithrombolytic agent. It will not stop the bleeding but help to protect the mother from developing DIC condition by preventing destruction of thrombus. Next, we will add injection oxytocin 14 units in 500 ml normal saline and start over 4 hours. It will not initiate uterine contraction but help to sustain the uterine contraction. Then we will insert urinary catheter and empty the bladder. This will enhance the uterine contraction as well as help to measure urine output. Still, if the bleeding is not stopped means we'll give injection carboprost 250 mics IM, at least 15 minutes between doses to a maximum of 8 doses. Contraindicated in severe asthma. Side effect includes pyrexia and diarrhea. Still, if the bleeding not stopped means we will administer tablet misoprostol 800 mics per rectum. This is less effective than injection carboprost. Side effect includes pyrexia and diarrhea. and we will continue uterine massage and bimanual uterine compression, and if you find any tear or injury, we will start to repair. Next, continuous assessment. Continuously need to assess for vital signs, intake output, estimation of bleeding, and assess for causes of bleeding. By this time, 30 minutes completed means second dose of injection tranexamic acid 1 gram need to give, and need to consider blood transfusion. According to the condition of patient and amount of bleeding, what are the products of blood we will transfuse means whole blood, packed cell, fresh frozen plasma, platelets, cryoprecipitate, and fibrinogen concentrate. By this, if the bleeding not stopped means need to transfer the mother to OT. If the patient is in primary care unit means need to transfer to secondary or high level care unit. After receiving the patient in OT, they will explore well and try to find out the cause. If found extended cervical tear, third and fourth degree perineal tear means that should be repaired by surgeon. If found inversion of uterus, that means the uterus standing inside out means try to place the uterus in normal position. If found uterine tear means start to repair it. If found vulvovaginal hematoma or broad ligament hematoma means will do incision and drainage. And in OT will insert uterine balloon tamponade. Balloon tamponade is a life-saving medical procedure used to control severe hemorrhage by inserting a Buckley balloon and inflating it to apply direct pressure against bleeding vessels. Procedure includes a catheter with a deflated balloon is inserted through the cervix into the uterine cavity, then filled with 300 to 500 ml of saline to create tamponade pressure. Still bleeding not stopped means will do uterine compression sutures. It includes B-Lynch, Heyman, and Choskor sutures. Still bleeding not stopped will do stepwise devascularization procedures. That includes bilateral uterine artery ligation, bilateral internal artery ligation, bilateral ovarian artery ligation. And rarely, uterus fails to contract and bleeding continues in spite of the above measures. At last, hysterectomy has to be considered in such a situation. Depending on the case, it may be subtotal or total hysterectomy. Next, management of secondary PPH. To find out the exact cause and to take appropriate step to rectify it. To administer tonics, to administer antibiotics as a routine, to assess the amount of blood loss and to replace the lost blood. The commonest cause is retained bits of cartilidone or membranes. It is confirmed by doing USG. It is preferable to explore the uterus urgently under general anesthesia, and the products are removed by ovum forceps. General curettage is done by using Flushing curette. The materials removed are to be sent for histological examination. Presence of bleeding from the sloughing wound of cervico-vaginal canal should be controlled by hemostatic sutures. Secondary hemorrhage following cesarean section may at the time require laparotomy. The bleeding from uterine wound can be controlled by hemostatic sutures. Rarely may require ligation of the internal iliac artery or may end in hysterectomy. Next, prognosis. Postpartum hemorrhage is one of the life-threatening emergencies. It is responsible for maternal deaths in about 10%. PPH also leads increased morbidity, includes shock, transfusion reaction, puerperal sepsis, failing lactation, pulmonary embolism, thrombosis, and thrombophlebitis. Next, preventive measures of PPH. Antenatally by improving antenatal care. During antenatal care, screening malnutrition and anemic mother and keep the hemoglobin level normal more than 10 gram per deciliter so that the patient can withstand some amount of the blood loss during delivery. High-risk patients who are likely to develop PPH such as twins, hydromnios, grand multipara, APH, history of previous third stage complication, severe anemia are to be screened and delivered in a well-equipped hospital. During intranatally, slow delivery of the baby is done. Baby should be pushed out by the retracted uterus and not to pulled out. Expert obstetric anesthetist is needed when the delivery is conducted under general anesthesia. Local or epidural anesthesia is preferable to general anesthesia in forceps, windows, or breech delivery. Active management of the third stage should be a routine. Temptation of fiddling or kneading with the uterus or pulling the cord should be avoided. Postnatally, examination of the placenta and membrane should be routine so as to detect at the earliest any missing part. In all cases of the induced or accelerated labor by oxytocin, the infusion should be continued for at least 1 hour after the delivery. Exploration of the uterovaginal canal for evidence of trauma following difficult labor or instrumental delivery. To observe the patient for about 2 hours after the delivery, and if the uterus remains hard and contract only, then she should be sent to the ward. I hope you got understand about PPH. Thanks for watching.